Hi everyone, welcome back to Module 3. This is going to be about behavior guidance, communication, as well as sensory modifications. We have a couple of learning objectives in this module. We'll go over how we can guide various behaviors in our office, different kinds of communication strategies. We'll go over sensory support systems, as well as how to manage red flag situations or how to spot red flag situations before they become crisis situations in our offices. On the right side are things that you might see in a patient with special healthcare needs once you see them in your practice. And on the left are listed lots of things that we can try, not just at the first visit, but also in subsequent visits. So, what you might see are sensory triggers. You might see certain tactile defensiveness where patients do not want to be touched. They get bothered with different textures. Remember that the dental office can be a very, very strange place for most people. So, if you add that to a patient who already has sensory concerns, you are going to see very different behaviors being exhibited by them. There could be a flight risk. So, somebody who just wants to run, we call them runners. They are being forced into coming and seeing you, but they really, really do not want to be there. And at the first opportunity, they're going to try and sprint. There's a lot of overstimulation, lots of new people that they're seeing, new equipment, new instruments. And if you add to that a kind of chaotic dental office where lots of other patients are being seen at the same time, there's too many people sitting in the waiting area around the time that these patients are coming in, that's a lot of stimulation for them. Many of these patients communicate non-verbally. They still communicate, but they're just non-verbal. And some patients just have a habit of saying no, 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 no. That doesn't necessarily mean that they're saying no to what you're asking them. That is just a way of them communicating. And I'll kind of explain that in a little while. What are some things that we can try? We can definitely make sure before we see a patient that we have a caregiver or a family member, somebody that the patient is familiar with. We would like for them to be there at the appointment. This is really key. This is the most important thing. If you get this right, believe me, your appointment will go a lot smoother. We can utilize tell, show, do, which is something you already see or you're already utilizing with a lot of your pediatric patients. We can utilize visual supports like cartoons and television. I personally try not to use them. I have maybe used them once or twice in my entire year so far. So if you are in an office that does not have a television, does not have, Netflix playing, you do not have to worry. You can still see patients pretty well. In my defense of why I don't like having televisions or screens in front of patients is I find that it often distracts them a little too much and patients are unable to focus on the task at hand. I would like for them to have minimal stimulation and have them focus only on one thing, and I would like for it to be their teeth and not be anything else. And this takes time when you're trying to get patients or imagine a toddler to focus on one thing at a time. It will take a lot of patience. And sometimes dental offices, we don't have that because we're seeing a lot of other patients too at the same time. And that's why there is a time and place for televisions and screens in general. We are trying to aim for short visits, especially the first couple of visits. We want them to be short, friendly, just a way for us to build rapport with the patient. Your team here really, really matters. If your team is trained well, they will know what to do, they will know how to respond to patients well. If your team is not trained, if you're throwing in a brand new team member into the mix, having them see a patient with special healthcare needs, things can really go south without any training. So, who the people are who are addressing this patient are super important. There are hacks that we can use for radiographs as well as intraoral photography. A lot of patients with special healthcare needs, when they see us, the first thing they will say is, I had a really hard time getting any x rays or pictures taken at the office. They tried all of this different stuff. I wish they simply used what you have because I couldn't sit through it. I was like, what did they use? And it turns out they're using the exact same stuff that we are using. There's absolutely nothing different. Maybe offices will try to put patients through a panel or make them sit through a CBCT. That can be really challenging to accomplish at a first visit because you're expecting patients to follow instructions, stay really still for maybe a couple of seconds. That's kind of a lot for someone who is brand new at your office and someone that has maybe multiple special healthcare needs or sensory or behavioral concerns. What we're really looking for is quick x rays, and the way we do this is by using a nomad. If you don't have a Nomad in your office, now is the time to get it. And of course, Nomad is just one brand. There are several other brands you can use, but we're really not looking for x ray techniques which have the patient bite on a stick and where your assistant runs out and presses a button for a couple of seconds because you're expecting the patient to sit still during that time. You may not have that kind of time with a patient with special healthcare needs. You have to be very quick. So using a nomad really is key. Um, if it's a patient with intellectual or developmental disabilities where we are seeing the patient for the first time, we have no idea what to expect. My assistants actually first try intraoral photography. We just have a simple, we have the simplest little stick from Mouthwatch. And again, this is just one brand. I'm not recommending it over others. You can try anything you want, but we try the wand first, see how patients do with it, and if they do well, then we add x-rays. If they let us do photos, then we know that even if they might not allow x-rays at the same visit, they probably will comply for x-rays at the next visit. So we're just trying to build on small steps. Stabilization rules. I will be going in detail over stabilization at a later time, but the most important thing about stabilization is that you have to get consent. You have to get consent from the patient or their power of attorney or their supported decision makers, whoever is in their realm of decision making. Everyone has to consent to this procedure. It doesn't matter which state you're in. Maybe your state has very loose rules around it. I would still protect your office first and foremost and get consent for these things. And of course, there's non-verbal gestures. So if you have patients with whom you cannot communicate verbally, touching their shoulder and holding their arm, having the assistant hold their arm when they're getting a shot, for example, all of these things really, really help in compliance. What are the keys to building a sensory friendly office? And of course, I understand that many of you are practicing at clinics where some of these things are not possible. But again, you can try your best to create as comfortable of an experience as possible. Reduce the noise in your office. How can you do that? Try to see patients first thing in the morning. Maybe if your regular schedule starts at 9, start seeing patients with intellectual developmental disabilities or any kind of special healthcare needs at 8 a.m. in the morning. Of course, not the hypertensive or cardiac patients unless it's a new patient exam. But try to see them in the morning where there's not a lot of stress going on. They are your first patient. You are physically and mentally also at your best when you're seeing this patient, and everyone's kind of all in and focused only on that one patient. Believe me, things will go a lot more easy. If you have quiet operatories or closed door operatories, these are the best situations. Of course, if this is not possible, then do the early morning appointments. Some of us have dimmable lights. Those are great if you're starting a brand new office. um, I cannot highly recommend having dimmable lights because this is really, really key. Some of the lights in our operatories are way too bright. If it's dimmed down, if it's a little bit dark, believe me, your appointment will go better. Weighted items. Actually, I know that the ADA has been going back and forth on certain protocols regarding the radiation shields that we use. However, I have found that that radiation shield that we place on patients actually works really well for patients with special healthcare needs. And if you don't have it, that's okay. But you can have a weighted blanket. Those are easily available on eBay or Amazon. Get one for your office and make sure you wipe it clean before every other appointment. But using it can be a game changer. We also have stuffed toys. We have like a little piggy and a little chubby unicorn that patients like to hold sometimes when they're going through a tough procedure. And as a blanket rule, I actually have my assistant offer it to everyone who is getting anesthetic. So it's not like we are only offering it to certain patients. No, we offer it to everyone. And the way my assistant offers it to patients is also very sweet. She was like, hey, you might not need it, but I would really recommend you hold on to this when we get you your shot. It will help make things go smoother. And she says it in such a sweet way that a lot of patients will actually accept it. So that works really well. And sometimes, of course, holding hands helps a lot of our elderly patients will hold my assistant's hand really, really tight when they are getting numb, and that's okay too. That's great. You can use headphones, which can block out ambient noises. I don't always use this in practice, mostly because, again, I want my patient to hear my instructions because I give a lot of instructions during treatment, or especially when they're getting numb. I don't want them to move, I want them to focus on their deep breaths. So I like for them to listen to only my voice, and that's why I don't always have headphones for my patients, but it can help in certain other scenarios. Have a staff that is pretty consistent. I know that in many of our offices, we have a lot of turnover. That kind of stuff, unfortunately, does not work for patients with special healthcare needs, which is also a reason why hospital dentistry tends to not be favored by a lot of patients and their families because they run into these issues where it's a new provider, a new resident, a new attending that they're seeing each time. And building that familiarity and rapport is hard. So, having two or three team members that are kind of consistent, that the patient is seeing time and time again, can be also very, very important. We talked about overhead TVs already, so I won't go over it again. And we also talked about AACs, alternative and augmentative communication devices, in one of the previous modules. You don't have to have these in place. You just need to ask the patient ahead of time if they have it and that they should bring it for their appointment. Same thing for iPads. Some of us don't have iPads in our offices. Totally okay. Ask the patient if they usually use an iPad to communicate, and they will bring it for their appointment. Or you can have pen and paper, you can have a little whiteboard, you can have anything that they need or that they are asking you to keep in place for them. Red flags. What are some of the red flags that you might see in our patients? Um, a red flag is basically any time that you're concerned for your team safety, as well as your patient safety. Patient safety could be because of any number of medical conditions, right? Your team safety is basically anything to do with certain behaviors that are being exhibited by the patient, which might not be exhibited on purpose, but they end up coming out, and they could, for whatever reason, jeopardize our team safety. So we have to try and look at these things in a um, very crucial way because we want to make sure everyone is really safe. The most common situations are the three listed below. elopement, aggression, and self injury. I have definitely seen one or two patients in my career who have wanted to run, absolutely run far away from what's happening. And I'll share what we can do in that situation. I have seen patients who have been on the aggressive side, and typically, this is a behavior that you would know about in advance of the patient. If your administrative workflow is super tight, your scheduler will let you know that this patient exhibits aggression and we need to plan for it before they come in. So we will go over that as well. And the last one is self-injury, which can be exhibited in maybe a very small number of patients. But again, this is something also that I have seen. If they begin to hit themselves or they begin to bite themselves or hurt themselves with their nails, anything like that, that's called a self-injurious habit. You do not want to treat a patient who is exhibiting signs of that in your office. It's not safe, not for them, not for you. So we need to figure out what we can do, what we can offer these patients in a safe way before we see them in our practice. So most of these conditions can actually be managed pretty well with some amount of oral conscious sedation. And their primary care team, or maybe their geriatric medicine team, their doctors essentially will have a standard way of managing these patients before they come in for your appointment. Because remember that we are not the only provider that they're seeing, the only healthcare provider. These patients are going to the hospital, they're getting blood work done, they're getting different kinds of appointments done, and they're exhibiting very similar symptoms and signs at all of these appointments. Most of my patients are given some amount of oral conscious sedation, and I always have their primary care physician put in a prescription for these medications, mainly because these patients are typically on lots of other additive medications. Remember, we talked about polypharmacy before. They are on other medications, and you really do not want to you do not want to interact with those medications um, in a bad way, right? You want to make sure that they are not taking too much of any one medication, because otherwise you are in a real mess. So always have the primary care physician write the prescription and have the medication be taken by your patient before they come to see you. I will typically always let the physician know that, hey, we are planning for a new patient exam. We have been told that they exhibit certain signs. We just need to get through x-rays and photos, and the exam is going to be an hour-long procedure. Or if I'm planning to do some extractions, I'll say, hey, we're looking to do 3 or maybe 4 extractions. I need you to prescribe a slightly higher dose of benzodiazepine, for example. Can you please have them take some medication the night before and then 1 hour before dental treatment? And most physicians will just follow your lead and get the prescription ready for the patient. Physical support and consent forms. So we talked briefly about stabilization in one of the previous slides, and this is kind of what I mean by stabilization. These are stabilizing boards, and some of these boards are meant to be placed on a dental chair with the support of this wrap, which you can see that this child is wrapped in. It's called a rainbow wrap, and this equipment is actually sold by a company called Specialized Care Company. I have some of their equipment. There are other companies, again, who build equipment like this, but I definitely do like what they have, and they tend to be kind of focused on patients with special healthcare needs, which is absolutely fantastic. This smaller stabilizing board also comes in for wheelchair rests. So when a patient is on a wheelchair, many of them actually do not have a headrest, head support. So the head kind of tends to wobble around when you're doing dental treatment. while they are seated in the chair. And so having that kind of stabilizing board behind their head can really help keep their head in position, not wobble around. It makes it a lot easier for you to do treatment on them too. I have only ever used this wrap maybe in residency, which was probably 3 to 4 years ago. I haven't used it a lot in practice. Why? Because I've just found other ways in getting patients to comply. In residency, we typically are seeing a very huge volume of patients, and we really need to get through treatment very quickly because patients have already waited several months to come see us. So at that point, they're very, very ready for treatment. Treatment has to be offered. So a residency program sometimes does not afford you with the time that private practice does, which all of you watching this actually can offer to your patients. I know I do. I will give patients 4, 5 visits to just get them desensitized so that they can comply for treatment. So, in private practice, have I had to use rainbow wraps and stabilizing boards? Not really, but it is definitely a tool to have in your toolbox. And whenever you use it, you definitely need to have a consent form. This is a very, very simple consent form, but you can have consent forms generated using AAPD guidelines and modify that for adults. And you can even have citations, you can have scientific evidence presented, you can show a video to patients before they sign up for it. And actually specialized care company gives you, you can give you a little model of a baby, like a mannequin baby, and they have a rainbow wrap around the baby. And so you show your patient or their family members what the rainbow wrap looks like and how well it can take care of the patient. Because really, the reason for a wrap is not for you to do treatment on the patient, it's for them to be safe. Because if they're moving their hands around, moving their, like stomping their feet about, they are going to cause injury to themselves. Dental instruments are going to fall on them. It's going to be a problem. And the goal of using rainbow wrap should be explained to families also very, very well. It's not supposed to be an every time thing. It's supposed to be a once or a twice or maximum 3 times thing. And after that, the patient should understand that, okay, I need to lie still, hands on my belly, feet in place, and keep my mouth open so the dentist can get work done on my teeth. That's the purpose of a rainbow wrap. It's not to be used all the time. And it's definitely not to be used as punishment. So, with that, let's jump into a case study. 48-year-old, again, heavy set male with intellectual and developmental disabilities who lives at home with his mom and has not had a cleaning or any kind of dental treatment in years. This is I believe in the first visit, we got intraoral photos on him. And you can see that there's a lot of perio going on. We haven't done any probing. I haven't looked into his mouth. I've just had my assistant go in and take intraoral photos, which I said is the first thing we do when we can kind of sense that x-rays might be a little too much for the patient. So we got intraoral photos. I can tell right away this is perio. He will need an SRP. So the first visit, he actually does not sit in the chair for longer than 30 seconds. So my assistant takes in one photograph, and then my patient gets up, goes into the kitchen, spits in the kitchen, in the sink or in a cup, and then comes back and sits in the chair. And he keeps doing that after every picture because just having the wand, the mouthwash wand in his mouth is maybe very stimulatory for him. And so he feels the need to spit. We even decided to keep a cup right there so he could spit in the cup and just sit in the chair, but he did not want to do that. He wanted to run to the kitchen every time. And he's a big man. He's 48, right? So imagine most of us, if we are females in doing treatment, we are pretty small and petite, and We have a heavy set meal, getting up and just darting towards the kitchen. It can be a little overwhelming. So these are things that you have to consider when your team is involved with this kind of treatment. Um, Again, I'm just harping in on team safety. That is one of our biggest goals when we're seeing patients with special healthcare needs. We have to make sure our teams are safe. So, mom is there at the appointment and she says, this is just the way he is. He does this for all of his medical appointments too. Does that help us when she says it? It kind of does because it gives us an idea of how he is in general. But remember, she's saying this is just the way he is, right? She's not giving us a whole lot of stuff we can work with. So, how do you proceed? Mom is there. You can ask her a lot of questions, right? Because she has been obviously with her son the whole time. She has seen him live his whole life. We can ask her a lot of questions to get good feedback and understand what we can do next. Do you try x rays after the intraoral photos or do you decide to stop? How do you think gaining cooperation for an SRP at this point is going to be? If you stop at intraoral photos, what are you going to try differently at the next visit? So these are questions that I want you to kind of think about maybe for a minute or so, come up with a game plan in your mind, and then when you're ready, in 5 seconds, we will move on to the next slide. All right, so what did we do? This is one of my go-to strategies. I use it almost 95% of the time. I always start singing songs, and that might be because I have a little toddler at home. But even before I had my toddler, that was one of my biggest strategies. I used to always sing songs because it's what my program director at my residency taught me. I heard her sing the ABC song repeatedly with patients with special healthcare needs, and believe me, it does work. It's not about singing the ABC song or the Wheels on the Bus song or Twinkle Twinkle Little Star. It's just music. Music can be very calming for most people. Use it as a tool and start doing that. So we started singing the ABC song just when I started opening his mouth and taking a look. So at intraoral photos, after that, I just said, you know what, let me take a look and let's see how well this goes. So I did an exam and I was singing the song, and it turns out that that was his favorite song. And his mom told us at that time that, oh my God, this is his favorite song. How did you guys know? And I said, I had no idea. We just tried it. And so what we did was instead of me having to sing the song repeatedly, my lead assistant just played it on her phone. So it was going on in the background while I was doing my exam. So the first visit just ended up being photos, getting probing depths. He allowed us for probing depths. And just doing an exam, realizing that, okay, we need to do an SRP. Next visit, we had his physician actually prescribe him some benzodiazepine, and he did a lot better. So with the benzodiazepine, we got x-rays in, and he did so much better. He wasn't getting up each time. The third visit, we increased his dose of OCS even more, just so that we could actually do a full mouth SRP without him having to get up all the time or get, at all bothered by the amount of treatment that we were doing. Because a full mouth SRP can be a lot for everyone. Luckily, what I wasn't anticipating is the fact that he recognized us. He recognized me. He recognized my lead assistant. He said hi. He sat in his chair. He knew we were from the dental team. He knew exactly what to do. He opened his mouth without even being prompted. So, familiarity had already built at that point, which I was super duper proud of. And actually, his next visit with us is going to be a few extractions because remember, he has a lot of perio, untreated perio. So, unfortunately, he does need to have some teeth pulled, and we're going to see how it goes. But based on our past experiences with him, I think he will be great for the treatment. So I don't worry about it. So, what are the key takeaways here? We start and we always end with safety. We have to take care of our team members if we want to see these patients, and we have to focus on our patient safety as well. Prioritize predictability. If you have someone in your office who has a heart for this kind of work, make them the sensory and the behavioral lead. Make them like the lead person who takes care of these patients. They will love that authority, they would love that leadership role, and they will bring a lot more love and patience to these patients than anybody else. So find that person in your office. All of us have these people in our office. Um, Focus on having short, very successful, predictable visits. Involve caregivers early. In the previous case, we asked lots of questions to the mom. We got information from her that helped us. So always involve them. Collaborate well with your primary care physicians, because I have been doing this for so many years now. I have seen most of the primary care physicians or the geriatric medicine doctors that see my patients are almost the same. We are a small and tight network of maybe 10 or 15 providers that see the same patients. So we all kind of know each other now. And I know how certain doctors do things, and that helps me. And when I mention that to my patients or their families, they feel a sense of relief. They feel like, oh, wow, you guys know each other. We are in good hands. That makes them feel good. And of course, case based decision making. No patient is the same. Everyone is different. Just because there are two patients with IDD on your schedule that day doesn't mean both of them are going to behave the same way or going to be successful. So, every single patient has their own unique situations going on, and we have to tailor make decisions or treatments based on that. With that, thank you, and I will meet you in our next module.